Hi, everybody. It's great to be back here. I'm Adrienne Shilton. I'm the Vice President of Public Policy with the California Alliance of Child and Family Services. And I'm here with Chris Stoner-Mertz, who is our CEO. Just as a reminder, I know some of you attended our part one, but wanted to remind folks about who the California Alliance is. So we are a statewide association. We represent 165 nonprofit community-based organizations across California. And the common element that brings all of our member organizations together under the California Alliance is that they are serving children and youth and families in public human services systems. And in addition to the California Alliance, we also have a nonprofit arm called the Catalyst Center. And the focus here is really about training and technical assistance and research and consultation to the child serving field, even more broadly than the California Alliance members. So together, through policy and technical assistance, we are trying to break down barriers to access to care for very vulnerable children, youth, and families in California. So in terms of what we're going to focus on today, we're looking forward to a very interactive discussion. I know our first presentation was in a webinar format, but now we can see all of you and really look forward to your questions and discussion points. So please, as was stated earlier, don't hesitate to ask us during the slideshow. We'd love to stop and have a discussion about that particular item. So we'll do a brief review about what CalAIM is and some of the new benefits that are available. And we really want to spend some time on this item around how community-based organizations and counties engage within CalAIM, with the particular focus around our managed care plans in California. And we'll also be talking about some examples of integrated funding opportunities that might be actually very relevant to the work that you do or partnerships that you have. So as a reminder, during the fall of 2019, our administration released a comprehensive proposal to transform our delivery of both physical and behavioral healthcare services in our Medi-Cal program. And this was known as CalAIM, or the California Advancing and Innovating in Medi-Cal. And so it was shortly before the pandemic, right, 2019. So due to the pandemic, our administration delayed the implementation of CalAIM in the 2020-2021 fiscal year. So the CalAIM reform efforts really officially began to roll out in January of 2022. And there are a suite of proposals that are being phased in over this 5-year period of time. We included a link here on this slide on the DHCS website to the CalAIM Behavioral Health webpage. This is an incredibly resource-rich webpage. I have it bookmarked, and this is a place where you can go to really track the behavioral health specific reforms that are being rolled out under CalAIM. So just encourage folks to take a look at that and bookmark it. CalAIM is an incredibly ambitious effort. Have the sort of big goals of the initiative listed here on the slide, but it's really about how we do better to incorporate evidence-based investments in prevention, in case management, and other non-traditional services into our Medi-Cal program. CalAIM also has a focus and seeks to reform our payment structures for both the counties and our Medi-Cal managed care plans. There are goals around really how we can streamline rate setting and reduce documentation and other auditing workloads for both plans, for both the counties and the Medi-Cal managed care plans, and their network providers, which are Alliance members in a lot of cases. The Alliance members are the nonprofits that are contracting in both systems to provide care to children, youth, and families. There are other components of CalAIM that we'll get into a bit in this presentation, including changes to populations and also services. that would be delivered as well in both systems. So the next couple of slides, we're going to focus on what's happening in our managed care system. But just as sort of a refresher here, there really are three systems which provide behavioral health services to Medi-Cal beneficiaries. We have our county mental health plans, which are often referred to, you'll see the acronym MHPs. And that refers to the mental health plans. We have our managed care plans, or the acronym you'll see a lot is the MCPs. And we also have local health plans as well. And so in terms of sort of responsibilities within each, the county mental health plans really provide that broad range of specialty services to individuals with more severe issues, challenges, mental illnesses. While the Medi-Cal managed care plans are really providing what are sort of known as the non-specialty, you'll hear that term, non-specialty services. But generally, some of the other lingo in the field that you'll hear is that they are mental health services for those with mild to moderate conditions. And also, just another term that you may have heard that we use a lot in our field, the delivery of the specialty services through the county mental health plans is commonly referred to as the quote carve out, which is when basically there are two services covered by the Medi-Cal program and delivered outside of a Medi-Cal managed care plan. And these specialty services are provided under a waiver that we have in our state, the 1915B waiver. This really governs the services that are provided there. In the next couple of slides, we'll cover high level, but encourage you to take a look at the links that we have provided with some more details. But just sort of going back to that, kind of in the area of like the changing landscape. So in 2021, DHCS, our Department of Healthcare Services, began a statewide procurement process of the commercial Medi-Cal managed care plans, the MCPs, and a new MCP contract. And these all became effective in January of this year. So this is all very new in terms of the new arrangement of plans and the new contract that the plans have with DHCS. And so as you might imagine, and some of you may have direct experience with this, working with people, is there were approximately 1.2 million beneficiaries that transitioned to a new health plan as a result of these changes. And in some cases, they actually had the ability, depending on what the arrangement was like, to select from more than one plan. But I think the big, the takeaway that we were, really thinking about for these next couple of slides is like beginning now. I mean, really beginning January of this year, 2024, the Medi-Cal managed care plans are subject to new requirements. They really are under sort of strict direction to advance health equity, to improve quality and access. And there's quite a few, new accountability measures and sort of more interest in our state to have more transparency so we improve this delivery system. So again, here's kind of just a summary of the last slide, and we included some helpful links. In fact, I just went to that explainer that's linked there as we were preparing for this, for this presentation. But I mean, here's sort of the landscape. We have 5 commercial MCPs to serve Medi-Cal beneficiaries in 21 counties. Some counties are shifting to different plan models: the 2-plan model, the county operated health system model, or the new single plan model. And then another interesting factor here that some of you may have known about or read about is that there's now a contract the state has with Kaiser to expand its Medi-Cal managed care plan contract to 32 counties, and also to begin serving some new populations that we'll talk about. So we also covered some of these initiatives on the first part of our Life Raft series, but There are quite a number of other initiatives in our state that are sort of interacting with CalAIM, other investments, other federal efforts. And we've listed some of those here, some of which the Alliance is very much involved with, including the Children and Youth Behavioral Health Initiative, which is a 5-year investment from our administration. It's 4.8 billion, almost $5 billion. And a number of different programs that are rolling out within this initiative. We have a real emphasis in our state around how we bolster community schools, which are partnerships with the schools, but also with community resources to support our students on campus or linked to the campus in some way. And some of you may be following the hot news about Proposition 1 that was on our March ballot, and it's too close to call, TBD, on whether or not that passes, but that's a significant overhaul of our Mental Health Services Act in California, in terms of new requirements on the counties, new funding arrangements and requirements, a new housing component. There are some sort of potentially very big changes coming should that pass, but we may not know the answer to that for another few weeks. There are still around 2.5 million ballots to count. And it is, I think the last count I saw, there were like 12,000 votes separating the two. So that sort of remains to be seen. But we wanted to there are, a number of other initiatives, at play here as we are very invested in the CalAIM space. We're also trying to make these connections around prevention, around schools, around, how we better care for our Medi-Cal population. So what parts of CalAIM impact children and youth? A lot. And we've listed those here, but what we're gonna focus on in this presentation is where I have the highlights, and we'll get into these, but enhanced care management and community supports, the utilization of the new community health worker benefit, and also some of the other justice involved initiatives, which are very exciting, that are also rolling out as part of CalAIM. So we wanted to call attention to children and youth as populations of focus under CalAIM and under enhanced care management, and in particular in terms of the increased role that the managed care plans in California will have in working with partners to serve children and youth. And this is literally from the policy guide, in terms of what the definition actually looks like. And as you see, it is quite broad, and there's quite an opportunity really to expand who we're working with. So this includes children up to age 21 who may be experiencing homelessness, other high utilizers of services, those youth who are experiencing others, serious emotional disturbance, or identified or at high risk of experiencing their first episode of psychosis. They could be enrolled in our California Children's Services programs. They could have a history or involvement currently in child welfare programs, including foster care up to age 26. They could be coming out of systems like transitioning from incarceration. And also there's a focus on pregnant and postpartum individuals. So for us, this is very exciting in terms of, having a broader role in terms of following kids. Like, a lot of our members are in the specialty system working with the counties and expanding that work. We'll talk about our Full Circle Health Network again, expanding that work with the plans to really focus on youth as they, are making their way across the continuum. So wanted to bring attention to this population of focus in particular. And we mentioned the enhanced care management program. This is a relatively new statewide Medi-Cal benefit within our managed care plan system. And this is really meant to address both clinical and non-clinical needs of both children and adults. This is about building those trusting relationships with the members, with the beneficiaries, and providing really intensive care coordination in terms of the healthcare needs of this population. So we've listed here, in terms of what that coordination specifically looks like. This really can include anything from physical health, behavioral health, to dental, to social services. Again, I mentioned the clinical and non-clinical needs. And, maybe most importantly is like, we are going to where individuals are. This is an at-risk population. They may be homeless or at risk. So, going to where they are in homes or in schools or, on the street in some cases. And this is work that, again, as their specialty behavioral health providers, our members have been doing in the specialty system, and really looking to expand that work and with new partners on the managed care plan side. Included a link here to a fact sheet it's a great fact sheet, by the way, with just some more details about what this is. And then also wanted to mention too that there's a program called Community Supports, and these are also services that are provided by our Medi-Cal managed care plans to address, health and health related social needs, and avoid what we hope is costlier level of care because we're intervening. And so, but unlike enhanced care management, which is a statewide benefit, which is a requirement, community supports, while they are, our state encourages the managed care plans to be offering as many of these 14 community supports as possible, they may not all be offered by every plan, or the full suite of community supports may not be offered by the plan. So these are optional, and we're continuing to track sort of the uptake of these, like, who's doing what is working well, and also highlighting just a few of these that really relate to kids and youth in particular. So really, all of the housing supports, the respite, other support for meals, and sort of those kind of basic needs supports, sobering centers, and asthma as well. We really see these as being really relevant and pertain to the population of focus around children and youth. And with that, I'm really happy to pass on some of the next part of the presentation to Chris.
Thanks, Adrienne. I want to pause for a minute, and just like that was a lot of information Adrienne threw out there. So just opening it up to see if there's any questions, and thanks to those of you that are putting stuff in the Q&A too. Any questions about anything we've gone through so far? Okay. While I'm talking, I would also love to have folks maybe put in the chat where you're from. So as we're getting into some detail about integrated services, how does this all fit together with, maybe what you all are doing now, whether you're a county or a CBO, it would be great to just have a sense of that, so we can try to really address what your questions might be. Lots of folks from counties. Love it. Great. All right. What are community health workers? This is a new provider title in the state, although certainly some organizations have people that would right now fit into that category. But essentially, this has been added to our state plan as a provider that can do services through the managed care plans. Some of the areas that this particular provider type would work on would be helping members to navigate the health system, providing cultural and linguistic supports to member or to beneficiaries, helping educating them around their health needs, and connecting them to community-based resources. Some of you have probably heard of promotores, community health representatives, navigators, violence prevention professionals. Those all could fit within this title of community health worker. And those services are, in fact, now considered medically necessary for members with chronic health conditions, including behavioral health, exposure to violence or trauma. Really, anyone that is experiencing a challenge or a barrier to getting their health needs met that are related to their social determinants of health and could benefit from services. Next slide, please. One of the key things that the state is really looking for in this community health worker position is folks with lived experience. And that's very broad in terms of what they're looking for. You can see that whole paragraph, which I won't read, but really anyone that has been system involved, that has had their own experience with behavioral health or substance use in the foster care system, that can also be they can also be characteristics around gender identity, language, etc. So really quite broad. And one of the questions we've been asked often is there a particular kind of certification or training for these community health workers? The answer now is no, although there are folks that are doing trainings, but there's no particular type of certification. Like we have now, instituted a peer certification in California. That's in discussion, and the Healthcare Access and Information Department is going to be working on that with stakeholders. So, next slide. Let me just pause and see if there's any questions about community health workers. I'm curious if anyone actually has any in their organization. Okay, well then there's opportunity if you don't. Another component of CalAIM is the Justice Focused Initiative. Yes, thanks, Jeanette. Yeah, a lot of, you'll see these community health workers in public health, I think a lot. And now this is really an expansion, right, into more of the social service organizations. Appreciate that. One of the other things that CalAIM is really focused on is health equity for folks who've been incarcerated and who are involved with the justice system. And of course, for youth, we certainly know there's a significant shift at the state level to they've essentially gotten rid of what used to be CYA and are looking for local public agencies and their contracted providers to provide more community-based services to support youth coming out of or in the justice system. One of those things is what's called an in-reach program, which is not yet rolled out, but will be shortly, that allows for provider organizations to support youth 90 days before they leave a probation setting and help them navigate as they transition out to get the kinds of supports and services they need. So again, another really new benefit through CalAIM that particularly for organizations that are already involved in working with youth through the probation systems, can add additional service types. And this is another way to claim for services you're doing that you may not have traditionally done. Okay. Adrian talked a little bit already about, the how foster youth are really called out in CalAIM, and they are seen as a very specific population of focus. And I know probably many of you actually are either connected to or serving directly foster youth and their families, or are perhaps contractors to do that. You really see a very strong connection here, and we'll go into a lot more detail in further in upcoming slides about this, but there's a real focus on the state's part to do as much as they can to both help keep children out of foster care, but for those who are in the foster care system, that they're getting access to these services. So any organization that has been working with that population of youth could be providing ECM, community supports, and/or community health workers. Managed care plans do not know this population for the most part. And they're looking for partner organizations to help them engage with, outreach to. So if you are a CBO, or if you're even a social services department, child welfare department, this is an area where engaging with health plans can really both be a new service line, but also really support the youth that you are already working with. So obviously these services have to supplement, not supplant, whatever they might already be getting in terms of services, but lots of this care navigation is adding on to what might already be available. For example, you might be serving a foster youth through the specialty system, as Adrian talked a little bit about earlier, through the mental health plan. But there may be some things that you can't necessarily provide in terms of facilitating healthcare access, that having these additional supports and engagement with you to provide. Similarly, you may be starting to engage around the prevention services through the Family First Prevention Services Act and the work that's happening there. But these are additional ways to support what you're trying to do in terms of providing prevention services. Next slide, please. This kind of digs in a little bit more into where you might see the different both service types and the provider types, right? So community health workers can really be that, I think of it as almost the mortar to your bricks. And because there's such a broad range of things that they might be able to do to help facilitate access and navigation of systems. But really any of these different service types and or provider types can assist you in doing more, hopefully earlier on in a child's life. Next slide. This is just a really, I think, such an important quote that came out of a paper that Center for Healthcare Strategies did. They did a piece, and we have a link both in the resource sheet and on this slide, about how important community-based organizations are to the CalAIM vision. They're critical partners in achieving health equity by elevating the voices of marginalized communities and vulnerable community members, and providing the culturally relevant, equitable, and strategic solutions to community challenges. So there, if you're a CBO or you work with a CBO, this is an area we really want to see more and more organizations get engaged with. The question is, how do you do it? And can be complicated. But we're going to talk a little bit about that now. Y'all are a quiet group. Please feel free to jump in if you want. Obviously, you have to start by engaging with managed care plans. Who are the plans in your county? And that's in our resource sheet, so you should be able to find that easily. You have to identify the people at the plan that's working with providers who are interested in these services. And you have to really understand how their rates are structured. How are you going to be able to do these services? You know, how many youth do you need to serve or families do you need to serve to make it work? How many staff do you need? Could a staff member that you currently have be doing some of these services on a part-time basis? And finally, and you will hear just a little bit of, I don't know if it's a commercial, but we're going to talk a little bit about a program or an organization really that we've stood up through the Alliance called the Full Circle Health Network. But it's just one example, and there are others out there that create hubs for smaller community-based organizations that can barely figure out how to write a grant and still want to participate in this huge initiative and are already working with these folks in your communities, having an organization like Full Circle, or we call a hub or a network, can be a really important way to engage in building those relationships. Because this network does all of that connection with the managed care plan, data and claiming and billing and all that administrative stuff that none of us really like to do, but no, it's part of getting paid. That they do that for you. And so you don't necessarily have to, you know, be really good at understanding all those pieces. We think it's a critical component to the health equity vision of CalAIM. And we'll talk a little bit more about that. Give you kind of a picture here of how this particular network works. It really is bringing together many CBOs. So far, there's about 70 in the network and growing, doing all of that referral and benefits and claiming and how do you quality metrics, etc., feeding that information to the managed care plans in the format they want it, because they're awfully specific about how they want you to bill, and they want you to do it through their EHR, not through a different. And so this type of a network really does all of that behind the scenes for you.
Chris, I wanted to read a question, I think,
great.
It's relevant in the chat. Thank you so much, Ashley, for asking this. So they have a first meeting coming up with MCPs in their area. How much negotiation, if any at all, can we do around rates?
It's a great question. I would say that it's always worth asking, and our experience has been that plans don't budge very easily, and it's once again one of the motivations for creating a hub, because power and influence in numbers. But you should start with it is technically a negotiation with the plan, so you should think about what your costs would be. It doesn't mean they will budge, but it never hurts to ask for what you think you need. Any other questions on that? Let's give a pause. Okay, let's keep going. We're going to pivot a little bit, and because I know many of you are involved as a county or maybe as a CBO with the Family First Prevention Services Act. And in California, we're calling it FFPS as opposed to FFPSA. Are many services that have been identified as evidence-based practices that can be utilized to support prevention and interventions that you might do with families. In order to claim Title IV-E, you have to do one of these evidence-based practices, many of which are very effective and tested through research, but also are expensive to implement. The state and the counties are still really in the midst of figuring out how to even claim these to Title IV-E. But when you think about if you have these evidence-based practices that you're looking to utilize and you combine it with enhanced care management or a community health worker benefit, many of these things can be done in concert and really support each other. And I'll talk about that actually a little bit more on the next slide, but just know if you haven't seen a slide like this, these are the California identified evidence-based. And to Adrian's point a little earlier, she talked about all the different initiatives. There is a very specific initiative that's happening called the BH Connect. That is a new 1115 waiver that is being put together that will support 3 of these evidence-based practices through Medi-Cal. That includes the therapy and functional family therapy. So there will be multiple different ways to provide and claim for these services, but it's another way these various different initiatives are really trying to support each other. You know, when the state looks at the big picture, they're trying to think about what are the ways we can use as much federal funding to support these efforts. So I thought I saw something in the Q&A, or did we answer that already, Adrian?
I actually know I was going to pull up another question, and this is also about Full Circle Health. So just so from Lindsay, do you know how small some of the CBOs working with these hubs like Full Circle Health are? I work with First 5 Kern, and we have a network of FRCs, but some are very small in some rural areas. And she's trying to assess whether this is beyond their capacity.
It is not. The entire intent of creating Full Circle is to work with small organizations. You'll see this on a slide coming up, but one of the issues with the rollout of CalAIM is that with the exception of those that are connected to a hub, the only organizations that are really truly engaging in direct contracting with managed care are something like $11 million or more in terms of their budget, which to me is antithetical to what we're trying to do vision standpoint, right? Those family resource centers are in the community, often parent-led, and it's critical to find supports for you all to be engaging in these services and providing these services. And when you look at where the state is trying to move us with the family prevention services, community pathways are critical. You're often going to be engaged with a family before they ever see child welfare or behavioral health, right? Because you're based in their community.
I want to
and supports. Yeah. Sorry.
Oh, just there. Sorry, Chris. I didn't mean to interrupt.
No problem.
Okay.
It's a conversation.
Yeah. So there's some great questions or comments in the chat. So just wanted to share from Victor, Charmel. Hi, Charmel. Victor Community Support Services is part of Full Circle Health Network, and we are in 15 counties across the state. So that's an example. Victor is one of the California Alliance members. Thanks for sharing that, Charmel. And then, Chris, did you want to say anything on that?
Well, I mean, I think Victor is an example of maybe a larger organization that's involved, but because they're statewide, having that hub is supportive of their work, right? Because that's a lot of counties to try to engage with. So thanks for getting that, Charmel. Anything you want to add? I saw you came on camera. Great.
And then Chris, there's a comment and question. What about travel time? So we are a large geographic county with our community pathway sites that could benefit from community health worker scattered all over the place.
Yeah. Well, the way this benefit is by encounter. So there isn't necessarily a payment for travel time, but I suspect that because what you're trying to do is really engage in different ways with different families. For one family, you might be going to the home. For another family, you might be able to via video or phone. So the idea is that if you're doing these encounters in various different ways with families or individuals, that ultimately that can sort of suss out or even out in terms of your costs. But it's a really important question, and I think we need to be paying attention to it as we look at the rollout and see, are there things that we need to suggest to, right, around things like travel time? So it's a great question. Appreciate that, Cindy. I got a separate question to just rename the EB are ultimately going to be claimable through Medi-Cal. And they are the parent-child interactive therapy, the multi-systemic therapy, and functional family therapy. And let me just clarify one thing. It isn't that that some of the components of these services can now be billed to Medi-Cal. What's going to be changing is that instead of, for example, I'll get a little nerdy on you and go straight Medi-Cal wonk on you. But if you're doing parent-child interactive therapy today and you're billing Medi-Cal, you're going to bill individual therapy for a piece of what you're doing. Then you might bill collateral services if you're working with the parent, or you might bill different components of the service. What the state is going to be doing is taking those 3 services, and they are going to literally create a code that you would use for whenever you're doing that service. So the idea is they want to simplify and make it easier for you to do that service and claim.
Chris, there's just another question in the sort of the theme around support for community-based organizations, especially small ones. I think I might need a little bit more information about what this means exactly, but the question is, are there plans to make contact facilitators available for CBOs with annual budgets below $11 million?
We don't know anything that the state specifically is doing, but again, that's why we've created Full Circle, because we know that it is really hard to do as a small organization on your own. It just isn't. Many people just it's not possible, frankly. The state has offered funding. They're calling it cited. I can't remember what the acronym stands for, to be honest, but that organizations can go after. But again, to write one of these grants, it's complicated. And so it's been very hard for smaller organizations to go and get funding from the state to help them stand up services directly. Okay, next
And there,
slide.
it was a typo, it was contract.
Yeah, I thought so.
Okay,
Thank
okay,
you.
that was,
Yeah,
all right, should we go to the next slide, Chris?
sure. Let's keep her moving. This just kind of provides a big overview of the when you think about prevention, there's different levels, right? Primary, secondary, tertiary. And if you look at the examples underneath, you'll see how some of these different either programs or service types can be integrated. So at a primary prevention level, and some of you are doing family resource centers, basic universal supports for families, right? From probably a food pantry to a, maybe you're doing our family resource center I used to run, did Zumba classes, navigation of employment, healthcare, other, how do I get eligible for Medi-Cal, for example. So you're doing those universal early supports for families. And like I said, you're often seeing them long before they might ever show up on the radar of child welfare. And then at the secondary level, this is where enhanced care management or community supports and the community health worker type might, provide more targeted supports to families and really help them identify how do they get these needs addressed. If there's family violence issues, and there needs more intensive behavioral health supports, housing supports, etc. How can those get addressed at that secondary level? And then on an even more intensive level, but still keeping families together rather than having them end up in the child welfare system. How do you combine these services with navigating the managed care plan to get individual or family therapy, maybe substance use intervention, or the specialty system as well, right? If you need wraparound services, those more intensive services in order to keep the family together. So all of these things can really weave together to address the family's needs. Okay, next slide. This is the slide that I was referencing, that while we know the folks are in need of the services on the ground are going to be much more comfortable going to their local faith-based organization or a family resource center or even a community center that they know. The research is showing that most CalAIM contracted providers are large organizations. And it's really, again, antithetical, I think, to the vision of CalAIM and the kinds of, at least financial supports that the state's been trying to put in place. So using that network or hub model can be a real way to address that sort of gap that we're seeing. Okay, and we're going to talk a little bit more about how this fits into the whole prevention landscape. This is a really nice diagram, I think, of how county child welfare departments are starting to think about community pathways. And if we have anybody from a child welfare department, feel free to jump in. But the idea behind community pathways, as they're outlined in the prevention plans that the state and the counties have put together, to support families before they ever step into a child welfare department or there's a call that has to be addressed. And so doing that is usually through those CBOs, right? So many counties are trying to figure out how do they build a pathway that doesn't necessarily start with them anymore, which is a huge shift, right? Like how does a family resource center identify a way through the child welfare department to get the supports and the funding to do these services? Well, one of the ways you do that is through the managed care plan efforts, the ECM, the community supports, the community health workers. And then you can determine, do they need more? Do they need one of those evidence-based practices? And maybe you're the provider that does that, or maybe someone else helping to navigate that by using these other claimable services. And so really helping people with that pathway is going to be so, and figuring. So the hard part with all of this is the implementation, right? It looks really nice on a PowerPoint, but getting the contracts, implementing the programs and the services, making sure you have the right staff in place. Those are the places where organizations and counties struggle. So, next slide.
Chris, just one question about this slide. How do we find out who our community hub or lead is?
Well, not every county has a hub. And again, it's one of the reasons we started Full Circle, because we felt like a statewide presence was needed. So if you'll have our emails, I think, as part of this presentation, but we can also put them in the chat, and we're happy to dig in with you, like based on what county you're in, and see if they're so happy to get you connected to Full Circle, if it made sense. So, okay, just one more sort of way that we see the different, this is kind of the stepping stones of whether it's Full Circle or another hub that you might get engaged with. One of the things that's, again, we're flipping things on their heads in terms of how children and families get services. Instead of, oh, I got to go to a public agency, which is what we're typically used to, or our health plan directly. Now we want to spread that out and engage them through their local organizations. So you, if you're a provider, might actually identify, let's say you're already working. I'll use Victor since Charmel's on the line. They have a wraparound program. They already know of, they might be doing a service for a young person through Raft, and that young person might have a relative or a family member that could also benefit and engaged with the child welfare system. And you, as the provider, might identify that and say, hey, we need to help this young person or this family get enhanced care management services through their health plan. And so the idea is we're really trying to find many more pathways and create a no wrong approach to services being available. But of course, changing a system like that takes a lot of work and a long time. But you as a provider could actually identify and help this family access these services. And then again, if you're either engaged directly with a managed care plan or through a hub, you would actually submit that referral for enhanced care management, community supports, etc. If you were working with a hub like Full Circle, they would actually help with that interaction with the plan and make sure that whatever referral or request you are making got to the plan, and then ultimately, when that is approved, comes back to you to provide the service. Did I see another question, Adrian, or?
Yes, couple. Let's see. Is Full Circle Health a free service offered through a contract or agreement, or is there a fee?
So right now it is completely free. In fact, through some cited funding that we received through DHCS, we've actually been able to even provide grants to organizations to help them with their hiring of staff. And over time, there would be a small administrative fee to help continue the support based on, your contracted. So there's like a 10% administrative fee that would go to support the network over time. But for now, it is being funded solely by supports through either the Department of Healthcare Services or other kinds of grants through the different managed care plans. We're actually one of Kaiser's 3 statewide lead network entities. So we're also in the 32 counties that Kaiser is serving. Do you have another question, Adrian, or did that cover it?
No, I answered the other 2 just in text.
Great. Okay, so since we have a family resource center here, you might do more than these things, but you're probably providing at least some of these: academic supports, employment supports, case management, maybe a food pantry, maybe support groups for families. Here's what you can do. You can provide these enhanced care management services, not necessarily supplanting a case management service, but if what you're doing looks different than what you might be doing under case management, enhanced care management. You can also hire community health workers. Maybe you already have a staff person at your family resource, fall in that category, but you haven't had a way to, maybe you're hiring them through grants. Maybe now this is a way for you to actually get support for the person who's doing that benefit. So it really can, we see family resources centers as a critical component to this picture. Really want to help them stand these services up. Thanks, Adrian. You go to the next one.
Just checking the questions.
Yeah.
Okay, one to ask, let's see. If a CBO were to provide enhanced care management, are they obligated to take all referrals from an MCP, or can they be choosy? In other words, stay within the population they already serve?
That's a great question. I think for the most part, I would suspect that they would want you to provide that service to whomever they might refer you to. And I feel a little bit like a broken record, but one of the benefits of being part of a hub is that you have a very wide range of providers that might, if you're not the right organization, maybe there's someone else that has a specialty with a particular population. But again, these services are very light touch. These are not the intensive specialty kinds of services, we're talking about providing through a behavioral health contract. So it just be navigating for them, helping them find those more, specific types of services in terms of the population that you're serving. So I don't know if that helps, but.
And we have a great question in here about, is Full Circle Health working with Siskiyou County? How can I get behavioral health on board? This is from Siskiyou County Behavioral Health, I think. Yeah.
I believe we are, but don't hold me to that. And if you send us an email, we'll make sure we get you to the right person.
And
And
then, oh, sorry, go ahead.
no, I saw Cindy. So is
Okay,
it
okay.
available to Native American Health Services? Yes, absolutely. It's available to any organization that's interested. Okay. I know how are we in time? We're doing okay. All right. Great questions, everybody. Thanks so much for your engagement. Okay, I know at our last webinar, we had a lot of folks, or at least a number of folks who did early childhood programs and were asking questions about early childhood programs implement this. If you are running a child care center or an ECE program, again, developing a relationship with a managed care plan or a network hub is really the first step. Identifying, do you have someone on staff or could you hire a staff person whose primary job might be to provide enhanced care management? This is such an important population because, again, from a prevention standpoint, you know the families, you are supporting the children already. They trust you. And so being able to provide these supports to that you're already serving can be a huge benefit and hopefully help keep children out of child welfare and get their health needs met early on. You might also decide maybe you don't want to do the actual services yourself. Maybe you want to partner with another community-based organization that already provides behavioral health services. One of the other new services that's really just rolling out is that the state has put in the state plan what's called a dyadic service. So rather than just the child being the client, you are working with the whole family, with the parent and the child. This is a new benefit in California, and there's a real emphasis, particularly for that 0 to 5 population, to be able to service. It has in the past been very difficult to figure out how to bill Medi-Cal to support an infant, for example. This gets rid of that and really allows you to bill to and there, of course, the other role that early childhood centers as well as family resource centers play is simply to let people know this is a benefit that they have. If they are on Medi-Cal, they are eligible for this benefit. Okay. One of the things I think that you can go to the next slide, Adrian, that we hear a lot from organizations is, how do I put all this stuff together? It's a big jigsaw puzzle of how you fit these things together. And frankly, I think counties probably as much, if not more than providers, struggle with this because you have all these different funding streams, but they all have their limitations. How do you make it work together? So we threw together this very brief example, particularly we often don't talk about transition age youth. So I picked, and we know that foster youth who are transitioning out of care, but want to be independent, are some of the ones that are most at risk. So this individual could be eligible for enhanced care management and community support. And again, I will put the caveat on, they do have to be in managed care. And one of the problems with what we have happening in California is that about 40%, maybe a little bit more, of youth in foster care are in what's called fee-for-service Medi-Cal and in a managed care plan. So if a young person is in foster care, but is in a county where fee for service is an option, and that is what the county has decided for them, they will not have access to these benefits. We want to change that, and we're trying to figure out how we help the state make that adjustment, but it will probably take some time. So we are assuming this young person is in a managed care plan for their health benefits. They could also be eligible for a transitional housing program. They are absolutely eligible for specialty mental health services up to age 21. It's wraparound or individual treatment, or if you're working with a biological family and making sure that they stay connected. And if they're in school, which hopefully they are, they might also be engaged in school-based behavioral health support. So there's lots of different ways with these new initiatives to access supports and services for youth. And it's still very much, unfortunately, localized. So in some counties, you have lots of schools doing the fee schedule through the Children and Youth Behavioral Health Initiative. What we really have to get to, in my estimation, is that we have to get to a place where we're doing all of these things more broadly across the state, and it doesn't have to depend on where you are, whether or not a service is available. So that's still a challenge, I think, that we have as a state. Okay, next slide. Here's one more example of how these various services might aid a family. And this is an example of a 6-year-old Sonia who was placed by social workers with her father after being removed from her mother's care. This was a relationship, that had not had a lot of connection for quite some time. And they needed a number of different supports. They needed stable housing. They needed to address Sonia's feelings of isolation and depression. She was having a lot of negative thoughts. And then the grandmothers was also involved and supporting the family. And it was an important and key part of Sonia's life. And she had her own health problems. So all of these various core needs between emotional, family, safety, school and work, housing, many of the things that families we all work with struggle with daily can begin to be addressed through these various different services. You could provide enhanced care management for Sonia and the dad. Maybe you are providing the grandmother with a community health worker who's really helping her with her health needs. You could provide, through community supports, housing support and transition, the navigation term rental support. There may be other things that aren't on this slide through other initiatives that we've talked about, but just staying focused on the CalAIM benefits. Those are the things that we might use to intervene and support the family. Okay, last slide, y'all. We use this slide courtesy of the California Children's Trust, who's been doing a lot of work in this, and I think has even done a couple of trends. This is just a great visual of some of the different and new things that are happening, not just under CalAIM, but in general through the processes that the state is working on to expand and make sure that all kids get services and supports they need. So peer-to-peer supports being supported through schools, demonstration projects, the peer specialist and the peer certification. This is, now happening now, and is again a new provider type that will be able to bill Medi-Cal. We talked about community health workers, doulas, have now their own bundled rate that they can bill for. That's another new one. We have wellness coaches that are now, we're just beginning to roll out the certification process and training process for wellness coaches in schools. And one other really important new thing that has happened, particularly with the managed care plan, is that now we can have associate social workers and MFTs providing services through the managed care plans. That happened through a bill that Adrian's going to tell us the number of, because I've forgotten.
That was Senate Bill 855.
855, yes. And the guidance has not yet come out, but it is in statute. And we've been very engaged in trying to make sure that that guidance looks the way we think it needs to for good implementation. So again, lots of emphasis on work with managed care plans. That is kind of the future of where I think we're going. Doesn't mean the specialty system isn't just as important, and that youth can absolutely, in some cases, get the services they need that really more adequately address their needs. But we really want to make sure that organizations have the capacity to work in both of those systems and support youth, both early on as well as throughout the continuum of care. So looks like we're at 1:18. So we have a little bit of time for more questions and dialogue if anyone has anything they'd want to chat about. I'd love to hear if anyone is actually doing enhanced care management or community support or has hired on community health workers. Anyone already engaged in that? Charmel is.
Yeah. Hi. So Victor at Victor Community Support Services, we are signed up with Full Circle Health Network, and we have started that journey providing ECM and community supports. And so we went live just last month, so February 1. So we're really excited about that. It is working out. And so I think that particularly with Kaiser just going live January 1, and it's a new program, it's a new service. So it's probably taken a little bit longer than what it will in the future. And so we're getting up and running. I think working with Full Circle Health Network has been absolutely amazing. I love that. I'm not trying to pitch them or sell them to anyone, but just from our experience, them already having the infrastructure in place has been really beneficial for us to not have to set up infrastructure for ECM or the RCM as well. And so that every Full Circle handles it. And so we really appreciate that. I really appreciate that we're able to offer this service not only to our current clients that we're serving throughout the state, but also we're able to broaden our net and our reach to be able to really make an impact with folks across different counties and the community that we're not currently engaged, folks we're not currently engaged in. So it's been a really good process.
It's great. Glad to hear it. Thanks so much, Charmel.
You're welcome.
I thought I saw another hand, but maybe it went down.
I saw it too. I think it was from Siskiyou. Was that Caroline?
Hi, yeah, can you hear me?
Yes, go ahead,
Yeah.
please.
Hi, thank you. I really enjoyed the information. I thought it was really helpful. But to be honest, I come from a school background, and I'm fairly new to the county, and I'm still trying to learn the system. And I'll be honest, I was a little lost just when it comes to like the fees and I mean, I'm sure with all the changes, probably, I'm not the only one lost. But I would love if there was like a training on, if there is one, or maybe even a previous one you can link, just so I can understand like the process from. So I work under the Mental Health Student Services Act, and so we
Okay.
work in partnership with the County Office of Education.
Yep.
And it gets real muddy. It's, they start Medi-Cal eligible students and
Mm-hmm.
yada, yada, yada. But I would just like, I guess, I would like to see the process of how billing works,
Yeah.
just
Oh,
from the beginning.
from
I
the
don't know if
beginning to
that's
the
even
end.
possible. Maybe I'm asking for too much.
What I think you're asking for something that many, many people feel like they need. So I thank you for raising it. And my guess is that some of the work that you're doing is supported through a grant through the Mental Health
Yeah,
Services
it is.
Act.
Yeah, a lot of it is, and that's so when I go to
Yep.
try and do something, they meaning my supervisors, bring it back to sustainability. Well, is the client Medi-Cal? Can we bill Medi-Cal? So it goes back to the whole billing, which I'll be honest, drives me nuts because I'm like, can we just help everyone? Yeah.
I'm with you. I am with you, Carolyn. And one of the other initiatives that we could do an entire, easily hour and a half on is the Children and Youth Behavioral Health Initiative. And I don't know how engaged your county office has been, but and it's still rolling out. But
Yeah,
what we have
I was going to
developed.
do my research as soon as we get off this webinar on it.
Okay.
It's all kind of
Yeah.
new to me.
Happy to engage, offline about that because we have been really engaged in the Children and Youth Behavioral Health Initiative. It's even the building of it. Adrian and I both sat on different work groups around the virtual platform and around the evidence-based practices. And we're on the leadership group at the state level on how the piloting of it is going. So lots to be done there. But the vision, going back to what your statement about all kids should get services, is that at a school that has decided they're going to utilize this universal fee schedule, that it would eliminate having to say, oh, this child can get that service and that child can't, based on who the payer, the insurance company is. So again, happy to talk more about that offline with you if you want.
Thank you very much. I'll definitely be reaching out to you both.
Great.
Thank you.
Yes, I was just going to add, please do. We'd love to engage with you and talk strategy.
Thank you. And if you do hold a training webinar on CYBH, I would definitely sign up and be part of that.
Super.
Thank you.
Great.
Great. Yeah,
That's an idea, Chris.
for sure. We need to do it. Well, we're at 125. How's everybody doing? Any other comments, questions? Did we get them all?
We got everything in the chat and Q&A so far.
It's a lot to take in, we know, and we probably didn't even go to the level of detail that some of you might want, but again, please reach out if we can be of help in any way. Do we have our emails on the slides? I can't remember.
You know what? I don't think we have them on the slides. So
Maybe we can get help getting them out. I'll put mine in the chat here. Oops, I sent that to one person. That's not going to work. But thank you, everyone, so much. Great questions, great engagement. Really appreciate all the work that you're doing out there, trying your best to get services to kids and families.
let's keep talking. Love to stay engaged with this group.
Great. We'll keep an eye on the Q&A as well as the chat. But on behalf of Caltrans, we just want to thank the both of you for your expertise, your time, and all the information that you brought today. We also want to thank all the participants for being here. And for those of you that attended part 1 and part 2, I'm so excited for you to put that information together. We are going to drop into the chat for you. We're going to provide a survey link. That survey link will give you access to a brief survey. And at the end of that brief survey, you'll have an opportunity to fill out a certificate of attendance for yourself that you could print out. So that is available for you now in the chat. And if there are no other questions, which I've been keeping an eye on to see if there are, I don't see any. Just I'm double checking. And if there's not, we just want to say thanks again. We're so excited to have had this opportunity for this training today, and we hope that you all have a wonderful rest of your week.